what treatments do you think are the most beneficial for patients whose CLL has relapsed? What are the poor prognostic indicators for CLL? And kind of along those same lines, what are the high-risk genetic markers for CLL?
Yeah. It's a little more complicated discussion in the first line setting because both are options. At this point in time, we haven't been, at least those that are, I would say, staying up to date on the CLL data, we have not been using chemotherapy for a long time. So most of the relapsed patients will have seen either one of the BTK inhibitors or venetoclax. And so what we do in the second line setting is just use the other option that they haven't seen. So the data tells us, when you look at what treatments are being prescribed, most patients are going on BTK inhibitors, and they have been around longer than venetoclax in general. So for a lot of patients, that relapsed treatment is going to be venetoclax because that has the best data in terms of treating patients that have progressed on a BTK inhibitor like ibrutinib or acalabrutinib or zanubrutinib. In the near future, we'll have pirtobrutinib, and so maybe some will get that drug before venetoclax, and that's probably okay. And so we'll have that additional option. The complicated patients, and I've alluded to this, are what do we do after BTK and BCL2? What are we left with? I mentioned PI3 kinase. That's not a great option. There's still stem cell transplant out there for young patients that are running out of options. Clinical trial is really what I would like to emphasize there. If you're a patient that can get to a high volume referral cancer center with a CLL specialist, I would do that if you have seen BTK and seen a BTK inhibitor and venetoclax and are looking for other options.